there's a lot of strategies to do this, but so far there are 4 major antibody program was approved. First one is Eli Lilly and Regeneron and GSK, and the Korean Celltrion got an approval from each country's also regulatory authorities. So the antibody program is gotten approval at this moment. And the next one is dexamethasone is a EMA approved this one as a immune modulators for the severe patient. And baricitinib, Eli Lilly, and tocilizumab is a Roche. This was approved in EU and EUA, JAK inhibitors and anti-interleukin 6, the immune modulators have gotten approval. And it's a later stage pipeline drugs at this moment. The upper 3 drugs are gotten through attention from the worldwide, especially for the second one, MK4482, molnupiravir. The name is very peculiar, molnupiravir. The Merck in the States, the MSD and Ridgeback, the small biotech company, developed their own project. So there's orally administered drugs, as you can see. The 3 of these antiviral oral small molecule drugs are getting attention from worldwide. The 4482 molnupiravir is about to get an approval from the United States, US FDA, and they also, MSD also would like to release their patent right to the small and medium income countries to manufacture very easily. So it's very, thanks to the MSD's decision, and monoclonal antibodies and plasma-derived human immunoglobulin drugs and other several drugs are developed at this moment, the latest stage. But the most important point is oral drugs for the antiviral at this moment. That's the most important 3 drugs at this time, because early stage patient, for example, early stage means the mild to moderate patient can take the oral drugs, then they can stay at their home to be treated and to be cared. So in that sense, this type of antiviral small molecule oral drugs will be a game changers for the battle with the Corona-19 virus. And monoclonal antibodies have shown very nice efficacy, but the problem is it's a monoclonal antibody. The administration method is, as you know, the intravenous. It takes about 2 hours, 1.5 hours in the hospital. So outpatient concern, it's very difficult for the outpatient to administer these monoclonal antibodies. So in this sense, we eagerly need small molecule oral drugs for the early stage patient at this time. Unfortunately, plasma-derived human immunoglobulin drugs already failed to show the efficacy to the patient. So this is many drugs worldwide. So I'd like to introduce about the Korean the status of drugs. In Korea, we carried the 11. The treatment was under development at this moment. Camastat is a TMPRSS2. The blockers is already phase 2B trial is already completed, and soon to be phase 3 trials will start. And as you can see, the Celltrion is already regular approval in Korean FDA. The Korean government or the authorities, they approved this one. And third one is nicotinamide. That's some kind of the depositioning drugs. So it's under development. Phase 1 completed, but we have seen some toxicities from this one, because nicotinamide is some the lipoposed drugs. So that's the reason we see the Piramax is another lipoposed drugs in the phase 3 is initiated last month. Then clavdin is a HBV virus the treatment. The phase 2 completed, and then waiting for the phase 3 approvals at this time, and nusepin and the several other drugs, 11 drugs. So we are expecting 2 or 3 drugs can be get an approval from Korean regulatory authorities sooner or later. So this is the current status of Korean development. Our strategies is very simple. Though we would like to focus on oral drugs for the early stage, the mild the stage patient. So usage of combination therapy, not only one drugs, but also the combination therapy, just like a Santa Cruz. So we give them lots of drugs. Combination therapy is beneficial for the patient at this moment. And the innovative therapies, we would like to support the innovative therapies at this time for the preparation to the neoantigens in the future. For example, COVID-24 or COVID-32. So we have to prepare this type of treatment for the futures. So the Korean government would like to emphasize on the innovative the therapies at this time. Then more support for fundamental the research, which means the COVID-19 pandemic is not this one only. That will start again and again. And five years is the normal duration between the pandemics. The next 5 years we have to prepare to fight against the neoantigens. For example, Corona 24 or Corona 26. Or I don't know which one will come, but we have to create many weapons to fight against new antigens, new pandemics. That's our the Korean government strategy. So in this sense, the KDDF, Korea Drug Development Fund, is as a government agency. On behalf of Korean government, we would like to support this type of research. So far, we support only Korean companies. We confined our investment in Korean companies, but we would like to extend it to the foreign small biotechs or foreign big companies or research collaborations between. So during this presentation, I hope to work together with Danish companies to co-develop the vaccines and treatment for the COVID-19. That's all I prepared today, and thank you for listening to my presentation. Thank you very much.
Thank you very much, Dr. Muk, for this very interesting talk and for the invitation to cooperate. That is, of course, very important. I think you gave a very nice overview of the status of the global vaccines and the initiatives in Korea, and of course also what you do in the KDDF. We will have, hopefully, I know we're a little bit behind time, but I'm sure we'll have time for questions after the next presentation. So please, if you have anything, you're welcome to ask questions after the next presentation. And also you can type in questions in the chat. I think we have people taking care of that, and then we can bring the questions forward later on. So now it's my great pleasure to turn to Denmark and to give the word to Professor Camilla Fode from the University of Copenhagen in Denmark. And Professor Fode will talk about Denmark's development and policy of COVID-19 vaccines. And we have Professor Fode with us online here. So please.
Thank you very much, Kde. Can you hear me and see my screen?
Yes.
Good. Thank you very much.
Good.
And I would like to thank the organizers for inviting me to give this presentation here at this exciting meeting. So I'll tell about the rollout of the COVID-19 vaccines in Denmark and the vaccines we are focusing on in the Danish program. I'm professor at Department of Pharmacy at University of Copenhagen, and I'm leading a group that is focusing on vaccine design and delivery. We are a very international group, and we started in 2019 focusing on mRNA vaccines based on the work we have done with protein-based subunit vaccines and oligonucleotides. We merged these two areas, and we got a grant from the Danish Council for Independent Research to work on mRNA vaccines using lipid polymer-based hybrid systems. So that was right before the pandemic, and it has been a truly exciting period for us with the rollout of two very efficacious vaccines. So we shifted to this area because the mRNA vaccines are really very flexible. You can design them very rapidly and thereby respond to future pandemics. So this was the agenda here. We had a quite efficient rollout in Denmark. We had to take out 2 vaccines in our national program. We have a challenge now with vaccine hesitancy. We are rolling out the 3rd shot, booster vaccination, and then we have 2 COVID vaccines in development, one in phase 2 trials and then one in preclinical trials. So if you look at the COVID pandemic here in Denmark, we had the national lockdown in March 2020. We could reopen the country again during the summer, but then we had the second wave here with a lot of COVID cases, and we had a very strict lockdown right before the vaccines were, or the vaccination was initiated in the end of December 2020. So this drop in cases is not due to vaccination, but due to very strict lockdowns. And then during the summer, we could lift all restrictions in Denmark due to high vaccination coverage. And now lately we see a quite rapid increase in number of cases due to the very contagious Delta variant, and also due to insufficient vaccine coverage to prevent increasing cases by the Delta variant. So that's a challenge we have at the moment in Denmark. If you look at the number of cases in Denmark and South Korea, then they were very similar until the second wave here, where the number of cases in Denmark increased quite a lot. We also increased the testing capacity quite a lot during the spring 2021, so we detected many cases. If you look at the number of deaths, then South Korea has been a bit more efficient than Denmark in preventing deaths, except for the latest couple of months, and I guess that's due to the bit higher vaccination coverage in Denmark compared to South Korea. So Denmark has this advance purchase agreement via the European Union, and 6 vaccines were purchased in advance. The 2 mRNA vaccines from BioNTech, Pfizer, Moderna, the 2 adenovirus vaccines from AstraZeneca and Johnson & Johnson, the CureVac vaccine, and the Sanofi GSK vaccines. The CureVac vaccine was not efficacious enough, and the Sanofi vaccine is still under development. So of the 6 vaccines, the 4 were approved by the EMA Community and Spikevax right before Christmas and in January 2021, and then a bit later the 2 adenovirus-based vaccines from AstraZeneca and Johnson & Johnson. And EU is still looking at these vaccines here, the Novavax vaccine and a few other vaccines. The vaccination program here in Denmark has been quite efficient. We started with the oldest persons here and went down in age groups until we came to age group 45 to 49. Then we also vaccinated the teenagers and then went up also, increasing age and then decreasing age. And the entire population has been offered vaccines. The latest group was the kids 12 to 15 years old that were vaccinated in July and August. So that has been a very efficient rollout, and we have been vaccinated in these central vaccination centers. This is actually my family. My dad was vaccinated in April, my daughter in June, and I was vaccinated in July in these centers here. So that has really been a very efficient rollout of the vaccines. So if you look at the number of vaccine doses administered, then we had quite a linear increase until July. And now the vaccination rate is really very, very low. It's difficult to vaccinate more people in Denmark due to vaccine hesitancy. And you also see here the accumulated number of doses administered in Denmark. So most people have been vaccinated with the mRNA vaccines, the Fisa BioNTech. 85.5% of the population is vaccinated with that vaccine, 13% with Moderna. Only approximately 50,000 persons have been vaccinated with Jensen, and very few with AstraZeneca due to the termination of these vaccines. So here I have a comparison of number of vaccine doses administered in Denmark, in South Korea, and in US. So South Korea and Denmark is at a similar level here. There has been a delay in South Korea compared to Denmark, but our two countries are at a much higher level than in the US. And if you see here, the share of people vaccinated against COVID, then Denmark and South Korea are very high here. So we are doing very well in terms of the vaccine rollout. Here you see the number of the share of people who have been fully vaccinated against COVID-19 as a function of time. You see the older age group has a very high vaccination coverage, whereas the young people are a bit more hesitant to say yes to the vaccines, and that's a challenge at the moment. These two vaccines here from AstraZeneca and Johnson & Johnson were taken out of the official vaccination program due to these severe side effects, vaccine-induced immune thrombocytopenia, where blood clots were observed in the brain region and also in the GI tract. It's a condition very similar to the one observed for heparin, where you have coagulation, platelet aggregation that gives thrombosis and blood clots. And the European Medicines Agency made a benefit-risk calculation for the AstraZeneca vaccine here at different infection rates. So countries with very high infection rates had a positive benefit of the vaccine. So the number of COVID cases prevented was compared to the cases of these blood clots combined with low platelets. And you see here that the higher the age, the higher the benefit of the vaccine. But in countries with very low infection rate, like Denmark, for example, there's only a benefit of the vaccine for the old age groups, not for the young people, and therefore it was decided to take out this vaccine from the national vaccination program. And that gave a lot of attention to the Danish vaccination strategy, because we we were missing vaccine doses at that point, so it was very controversial to take out the vaccine from the national vaccination program. And that leads me to vaccine hesitancy and trust in authorities, because I think this takeout of the vaccine actually stimulated the trust in the authorities, that the Danish health authorities are actually taking care of people, are really aware of side effects, and the communication around these vaccines here were very transparent. That is helped by one of the projects we have in Denmark, the HOPE project, that is monitoring the population's response to the COVID pandemic and also to the vaccines. So we are continuously monitoring how the population is responding to the pandemic and to the introduction of the vaccines. This is data from the HOPE project that shows the willingness to get vaccinated. The blue area here represents fully vaccinated people as a function of time. So we can see here that 87% of the population is vaccinated, or 87% of the eligible population in Denmark is vaccinated, corresponding to 75 or 76% of the total population. We still have people that are not willing to accept the vaccine. 5% are hardcore anti-vaxxers, and a small fraction can maybe still be convinced to take this vaccine here. And if we compare Denmark and South Korea, I think these data are more than 1 month old, so I think the vaccination coverage in South Korea is quite comparable to Denmark. We still have 16% unvaccinated people. We have 4% that are not sure if they're willing to be vaccinated, and then we have 3% that is still willing to get vaccinated. So this part of the population, that's the main problem at the moment. So the willingness to get vaccinated really depends on how much people trust in national public health authorities and also in scientists in Denmark. And we have very high trust in our public health authorities. The authorities have focused a lot on transparent and honest communication. There's been good communication about how the efficacy and safety of the vaccines. What can convince people to get vaccinated is that they accept that COVID-19 is a personal health concern, and it also helped to debunk myths of these COVID-19 vaccines, for example, conspiracy theories. But the challenge for Denmark, despite that we have a very high acceptance rate, is that the threshold for herd immunity is as high as maybe 90%. So even though we have a very high acceptance rate, it's not sufficient for herd immunity. And at the moment, we discuss if we should vaccinate children 5 to 11 years old to reach that number of 90% immune people in the population, the herd immunity. We have started booster vaccination, the 3rd dose, for people in nursing homes, for people with a weakened immune system, people aged 85 and over. We have also offered one more shot for people vaccinated with Johnson & Johnson vaccine. So that's the mix and match vaccination, where we offer an mRNA vaccine to people that had one shot with Johnson & Johnson vaccine. We also started vaccinating people aged 65 and over, 6 months and 2 weeks after their 2nd shot, and healthcare professionals and people at increased risk are also offered the 3rd dose. So we had our own vaccine in clinical trials. It's a Danish vaccine that was developed at University of Copenhagen in collaboration with AdaptVac and Bavarian Nordic. It's a protein-based vaccine where receptor binding domain of the virus is attached to a kind of an artificial virus component here. So you get these virus-like particles that induce very efficient immune responses. And this vaccine here is now in phase 2 studies. It's very safe, it's very efficacious, and it's stable. It can be stored at room temperature. The production is quite relatively easy. It can be produced anywhere in the world, so it's much easier to handle the production than the production of the complex mRNA vaccines. We have also a DNA-based vaccine in development by the Serum Institute in Denmark. It's not in clinical trial yet, but it's stable and can be stored at 4 degrees. I have not seen efficacy data yet, but the clinical testing is expected to be initiated, and it might be ready in 2023. So the corona crisis has really been the moon landing of vaccine research. Vaccines have been developed in record time, and that's actually due to these entirely new vaccine platforms, the mRNA vaccines and the adenovirus-based vaccines that are super fast to develop. The mRNA vaccines have been shown to be very safe and efficacious. They have been the major vaccines used in Denmark, but herd immunity is still challenged in Denmark due to vaccine hesitancy. Revaccination is needed for these mRNA vaccines because immunity decreases and we have reduced immunity against the new variants. We don't know the long-term efficacy of these vaccines. How long will the immune responses last? Will we have the need for more revaccinations than the third dose? When do we need herd immunity? We would need probably to revaccinate against new virus strains. We heard that from the previous lecture. There might also be need for mucosal vaccines that can induce stronger immune responses at mucosal surfaces and then prevent infections. So they're expected to be more efficacious than the injected vaccines. Vaccines for low-income countries are needed, thermostable vaccines that can be distributed independently of the cold chain, and we really need to be prepared for future pandemics. So that was what I prepared. Thank you very much for your attention.
Thank you very much, Dr. Fogel. That was a very interesting overview of the Danish approach. And I especially liked all the curves you showed showing Denmark and Korea. And it's amazing to see how alike we are also in this area. We're really following each other. So again, a lot of room for exchanging experience and collaborating on new solutions. We have time for some questions now. And if you have some here, you're welcome to raise your hand. And also, if you back down there could help me if there are any questions online. Yes. So, yeah, we have a question.
I have a question to Camilla. Thanks for your presentation. I have 2 questions. One is, are there enough clinical trials for children at the age of 5 to 11? So I'm just curious as a father who has a son at the age of 6. So, and another question is that I heard really good news about your efforts to build the vaccine in Denmark. And I wonder about your strategy after all. After all, you passed all phase 3. Are you going to make the protocol available to the third-party countries as well, or what is your strategy? Let's say that you are successful in developing it.
Yes, the first question about the vaccine for the kids, the Fisa vaccine has been approved by FDA in the US on Friday evening. That was Danish time. It's a reduced dose. It's 10 microgram compared to the 30 microgram given to the adolescents and the adults. The data looks good. The efficacy is 91% for the kids, and the safety look good also. Still, it's a limited number of participants in these clinical trials, but it looks like the safety is as good as for the 12 to 15 years old, or maybe even a bit better. So I think this vaccine will be given to the American kids from this week on. I think the CDC will recommend it. So the other question was the Danish vaccines. I think Bavarian Nordic is open to collaborations about phase 3 trials of their vaccine. Data are expected in the new future. This vaccine is inducing very high antibody responses, higher than the mRNA vaccine. So to me, it looks very interesting. Did that answer the question?
Are you going to make the protocol public?
Yeah, no, not for the Bavarian Nordic vaccine. I don't think so. No. But I think they're willing to enter a license agreement.
Thank you. Any other questions? I was thinking about something, Dr. Muk, maybe you can answer. We heard Dr. Fod talk about this hesitancy to get the vaccine, but both countries has quite a lot of coverage so far. But have you any thoughts about how to increase the number of people getting the vaccines? Any specific activities that you do?
For Korea, the vaccine hesitancy is not so high because everybody in Korea pay full attention to their health so far. So we have some people with hesitancy at this time, but actually the Korean people is very open to get the vaccination at this time. That's very the fortunate person. Thank you. But I have a question to Camilla. So in this situation, phase 3 trial is getting very difficult because very small number of people, the patient at this moment. So in this regard, how do you clear this type of challenges of phase 3 trials?
Yes, fair. This vaccine, which is now in phase 2, is both tested as a booster to the other vaccine and as a primary vaccination scheme. But you're right; it's more difficult now to test it unless it's a booster. But I think it's a very promising strategy to boost mRNA vaccines with a protein-based vaccine to get a broader immunity.
Okay, then your strategy is to create the booster vaccines for the mRNA vaccines.
Yes.
So, okay, yeah, I understand that. Okay, thank you.
Yes, any other questions? I just have a final question maybe for both of you. So we need to have about 90% people vaccinated to get this herd immunity. But what we also see now is that people that are vaccinated actually get the infection and can also pass it on. So do you think it will be ever possible to get this herd immunity?
Okay, then for me, the herd immunity, yes, theoretically it's true to get the herd immunity in the society, but actually the variant and the natural decay of the titer, so it hinder the achievement of herd immunity. So we have to get some third shot or booster shot or taking a mask for protection of ourselves. So theoretically, yes, but actually it's impossible to achieve herd immunity.
Thank you.
Yeah, I agree, but we now have background immunity in the population, so at some point the COVID-19 will be more like a flu. We don't get that ill because we
Yeah.
have some background immunity, and then we can maybe revaccinate the vulnerable groups like the elderly, the immunocompromised. Still, we have part of population with no immunity at all. That's the problem,
Yes.
and they pass on the virus to unvaccinated, but also to some vaccinated. But you have a higher virus spread when you're not vaccinated, so that we can prevent by vaccinating the last part of the population.
Thank you so much.
Thank you.
So if there are no further questions, then we will move on to the next exciting session, which is about smart hospitals and super hospitals. And it's my pleasure to go to Korea first, to Dr. Im Young-Lee from KHIDI, whom I was also honored to meet when I was in Seoul a month ago. And Dr. Im will talk about the Korean smart hospitals situation and policies. So please, Dr. Im.
Hello, Hello, ladies and gentlemen. I'm Young-Lee Im from Korea Health Industry Development Institute. Today, I will introduce Korean Smart Hospital project. As the current global spread of COVID-19 results in restricted physical movements at home and abroad, the traditional face-to-face lifestyle is shifting towards an untagged one. This new paradigm is not an exception in the medical services area as well. Accordingly, there is increasing demand for expansion of untagged medical services, and the digital healthcare market is also expected to grow continuously. In this context today, I would like to introduce Smart Hospital project in Korea. This presentation will be divided into 4 parts, starting from a brief introduction of KHIDI, followed by the necessity for digital healthcare, Korean New Deal and Digital New Deal, and Smart Hospital project. Introduction of KHIDI. KHIDI is a government agency under the umbrella of Ministry of Health and Welfare, located in Ulsan Health Technology Administration Complex with Korea Disease Control and Prevention Agency, Ministry of Food and Safety, National Institute of Health. It is established in 1999 in order to raise international competitiveness in the healthcare industry and improve public health by professionally and systematically undertaking projects to nurture and develop the healthcare industry and enhance health services that can respond to internal and external environmental changes. Major activities of KHIDI. First, policy development for healthcare industry. Second, support on healthcare R&D. Third, fostering healthcare industry and supporting business. Fourth, enhancing international competitiveness. From now on, let me explain why digital healthcare should be introduced. The biggest reason that justifies the introduction of digital healthcare is the aging of society. Population aging is accelerating worldwide, and the growing number of patients with chronic disease is increasing medical expenses. In particular, as the rapid growth in medical expenses of the super-aged population at 65 or older is emerging as a big social issue. Countries around the world strive to find solutions to solve this issue. As you can see, national health care expenditure is 8.1%, which was lower than the OECD average, but the rapid increase emerged as a social issue. The healthcare expenditure increase rate from 2005 to 2015 is 6.8%, which was the highest among OECD members. There is also a growing need for improved medical security for medically disadvantaged classes, including citizens in deprived areas and persons with disabilities, and a need to resolve health inequity between social classes. Many countries in the world experience rapid urbanization, and Korea also went through the urbanization at a rapid speed. A rapid change into urbanization widens a gap in medical resources, causing problems in access to medical services. Now I will explain Korean New Deal and Digital New Deal. As a Smart Hospital project stems from Digital New Deal, for your understanding, in this part, I will briefly introduce national strategies related to biohealth and Korean New Deal. In 2019, the government announced national strategy in the field of biohealth. It included ecosystem for technology development, 5 big data platform, and data collection, disclosing, and urbanization. Also, in 2020, the government announced the national strategy of this Korean New Deal. Korean New Deal consists of 3 parts, which are Digital New Deal, Green New Deal, and Stronger Safety Net, to accomplish a smart country, a green country, and a safe country. Now, let me explain Korean New Deal in detail. As I mentioned, Korean New Deal divided into 3 parts: Digital New Deal, Green New Deal, and Stronger Safety Net. Digital New Deal is to promote digital innovation and dynamics in the economy. Green New Deal is to accelerate transition towards low carbon and eco-friendly economy. Stronger Safety Net is to strengthen basis for a people-centered and inclusive country. While pursuing this Digital New Deal and Green New Deal, we expect to increase investment in human resources to create new jobs by creating new markets and demands, as well as accelerating innovation and investment in the private sector. Government selected 10 key projects in Digital New Deal: data dam, AI government, and smart healthcare. In Green New Deal, green remodeling, green energy, and eco-friendly mobility of future. Digital and Green New Deal, green and smart school, digital twin, digitalization of SOC, and smart and green industrial complexes. Smart Hospital is one of the 10 key projects of Korean New Deal by fostering untapped industry. Now, Smart Hospital project. There are some changes of healthcare paradigm. In healthcare technology, HEST, record and evidence-based treatment using medical materials, devices, hardware, and medical supplies. At present, real-time evidence-based treatment using medical platform, wearables, big data, health record analysis. But in the future, prevention, precision medicine, using medical solution, robot, AI, and AR. In other aspect, process of healthcare innovation driven by data. It can be origin of data, process of data, and areas of adoption. Other changes is 4P. 4P is predictive, preventive, participatory, and personalized. For instance, from provider-oriented to consumer-oriented, from treatment-focused to prevention-focused, from solid boundary of industry too vague boundary of industry. Now I will explain Smart Hospital project. Smart Hospital is a hospital offering medical services through the application of 5G and IoT for improved medicine in terms of enhanced safety for patients and increased quality diagnosis and treatment. It is for effective integration and pursuit of various services for patients through cooperation and adjustment among suppliers for provision of comprehensive services. It includes, first, pursuit of realization of smart healthcare in combination with diverse digital technologies based on medical information. Second, efficient and effective provision of care services, core services for the existing serious disease, emergency and acute periods of surgeries. Third, pursuit of sharing and connecting data among service providers through medical data platforms within areas. And fourth, support for realization of primary and secondary smart medical institutions, expansion of connectivity among regional medical institutions, and enhancement of healthcare management services based on improved consumer value. As part of the Digital New Deal Initiative 2020 in medical services, Korean government has supported the development of advanced model for smart hospitals, seeking to bring digital transformation to hospitals and enhance patients and clinical staff experiences. From 2020 to 2025, we planned to develop at least 18 advanced models for smart hospitals. In 2020, with the theme of infectious disease response, we chose 3 parts, which were tele-ICU, infection control solution, and resource management solution. And 5 hospitals participated in the project. First, tele-ICU. It is to monitor severe patients in middle-sized hospital from tertiary hospital. There is eICU command center, and doctors of tertiary hospital can monitor the patients and consult to the medical staff in middle-sized hospital. One tertiary hospital may monitor 5 to 10 other hospitals in the same province. We expect the tele-ICU system will be expanded to not just ICUs, but also designated hospitals for infection. COVID-19 patients with severe symptoms receive intensive treatment in the ICU, and integrated eICU command center monitors essential information of patients, such as biosignals in real time. In addition, contact-free online consult system is used by medical personnel to share patient information real time, which helps to support decision-making on treatment. Going forward, integrated eICU command center will help to narrow the gap in quality of care for ICU patients across different hospitals and resolve the problems of shortage of medical personnel in the ICU through integrated management of ICUs. And the contact-free multidisciplinary consult between regional hospitals and tertiary hospitals. Infection control solution. This model is developed to respond to the pandemic appropriately within the hospitals and regions. For example, patients visiting the hospital fill out COVID-19 questionnaire on their mobile phone and download the entry QR code. Patients can then enter through the speed gate without needing to prepare documents or register at the kiosk. While roaming around the hospital premise around the clock, quarantine robot will detect people not wearing masks or densely gathered, and will advise them on social distancing and the use of masks. The robot is equipped with hand sanitizers and UV sterilization feature, which help to support the hospital's disease prevention system. Hospital facilities that can be a medium of contagion, such as the outpatient kiosk, information desk, and handrails for fall prevention, are UV sterilized by the quarantine robot at night. Based on COVID-19 patient age, body temperature, underlying disease, and etc., or AI algorithm triages the patient and proposed appropriate treatment facilities, supporting medical teams' decision-making and reducing their work burden. Temperature of COVID-19 patients in quarantine can be checked real-time through the Bluetooth thermometer, while pulse and echocardiogram can be checked through a wearable ring. Biosignals can be continuously monitored from the nurse's station and other places. Support for real-time body temperature checks, as well as mental care for anxiety and depression, are provided for patients with mild symptoms who have been admitted to the residential treatment center. Resource management solution. DSI is a robot, and this is an AI-based robot that delivers medical supplies from pharmacy to injection room in a safe and speedy manner, reducing interruption to care due to delay in delivery, and cutting down on simple repetitive work, relieving fatigue of the medical teams, allowing them to focus on patient care. The robot also supports error-free delivery of medicine and medical supplies by utilizing finger vein recognition technology. In highly equipped and crowded operating rooms, real-time location tracking system helps to check the location of equipment scattered across the multiple operations theater, so that the medical team can promptly arrange unoccupied equipment for other surgeries, which makes resource management more efficient. In 2021, we are developing the models with the theme of patient safety. First, safety management. Second, smart unit for cancer unit and psychiatric hospital. Third, intelligence workflow. This model will be developed at the end of this year. The government will support the development of advanced model for smart hospitals, selecting 3 areas each year, and 18 in total by 2025, while seeking to expand such models to other medical institutions. We aim to continue digital innovation in the field of medical services by bringing visible outcomes that can truly be felt by patients and the medical teams. We look forward to safer treatment for patients, greater patient focus by the medical teams, and a far more efficient hospitals. This is end of my presentation. Thank you for listening.
Thank you very much, Dr. Im, for this very good introduction to both the Korean New Deal and the Smart Hospital project. I think it was actually very nice to see this robot, the AI robot that delivers samples and medicine, because I recall it from my visit in Seoul a month ago. We went to the Dongsan Medical Center in Daegu, and we were actually accompanied by this robot when walking around the hospital. So yeah, nice to see it again. So if you have any questions for Dr. Im, we will take them after the next presentation. So please, keep them in mind. And now it's my great pleasure to give the word to Mr. Peter Mantrap Jensen, who is the Deputy Chairman at the Danish Association of Healthcare Management, and also a former Vice President of the North Zealand Hospital in Denmark. And Mr. Mantrap Jensen will talk about the Danish super hospitals, situation and policies. So please.
Thank you, Your Excellencies, ladies and gentlemen, dear friends within healthcare. It's a great honor and pleasure to be here today and share some of my experiences, thoughts, and try to learn from you. The former presentation was extremely inspiring, so I'm looking forward to further debate on some of the issues. Short introduction on myself. I am today an independent consultant. I am past president of the Danish Organization of Management and Leadership in Healthcare, and have been for 7 years a deputy CEO, senior vice president at a hospital north of Copenhagen for 7 years. Before that, I was a CFO at the Danish Capital Region, also for 7 years. The picture on this slide is quite beautiful, I think. I'm not quite unbiased because it's the hospital I had a part in planning. But it is the most beautiful hospital we are actually building today in Denmark, I think. It's not there yet. I drove past it a couple of days ago, and you can see some of the basements, but nothing real hospital on top of it yet. Some short remarks. On Denmark and Korea. I haven't had the pleasure of being in Korea, but I hope there'll be a chance sometime. There are a lot of similarities, and I was actually quite interested in the similarities between our countries. Korea is a bigger country, very densely populated, but talking about health, the average length of life in Korea and Denmark is approximately the same, a little longer in Korea than in Denmark. I looked at breast cancer survival after 5 years, almost the same survival rate after 5 years. I looked at colon cancer survival after 5 years, and there Korea was somewhat in front of Denmark. So in my perspective, you have a very excellent treatment of cancer. Infant mortality very low in both countries. Vaccination of children's very high in both countries. A general coverage in both countries in the healthcare system. One difference I'll go a little further into is in Denmark we have a system with general practitioners, which we have to a greater extent than you have in Korea, I think, so I'll go a little into that. Spending of healthcare a little higher in Denmark than in Korea. Insurance, private insurance a little higher than in Korea than in Denmark. And the growth in spending money on healthcare is much higher in Korea than in Denmark, where it's quite moderate and has been moderate for some years. Talking about money, we'll not talk only about money, but a little about money. The share of healthcare spendings in hospitals in Denmark and Korea is around the same thing. It's a little more than half of the spending. The share of spending in hospitals on inpatients is around the same size in Korea and Denmark. Staffing. There are some interesting differences between our two countries. We have more doctors in Denmark. But strangely enough, the Danish population actually has fewer consultations per year at the doctor than in Korea. We go approximately 4 times to a doctor per year in Denmark, while you go around 16 times per year to see a doctor. The number of consultations per doctor is also very different between our two countries. A few words about the hospitals. There's quite a big difference in number of hospital beds per inhabitant. In Denmark, we have per 1,000 inhabitants 2.6 hospital beds, and in Korea there are 12. So that's actually a 4-fold difference. I think it reflects in the average length of stay in hospitals. It's quite short in Denmark. It's one of the shortest in Europe and perhaps the OECD countries too. It's around 5.4 days, while in Korea you stay around, as an average, 18 days per discharge. Technology, both Denmark and Korea are quite advanced, and number of MRI scans and CT scans are approximately the same. So that's my understanding for some of the differences between our countries, but a lot of similarities too. Short, the Danish healthcare system, we say it's based on 4 pillars: universal coverage, which you also have. We have what we call free and equal access to healthcare. There's the difference in the financing. We finance a great part of the Danish healthcare system by taxes. It's around 80.4%, so it's much bigger than Korea. You have a system with a mandatory insurance, so that compensates to some degree of the difference here. So Denmark in financing, we look like Norway, Sweden, Canada, Italy, and other countries like that. We have a relatively high degree of decentralization, which leads to the next slide. We talk about the 3 levels, the state level, the regions, and the municipalities. States, that's legislation and so on, national healthcare policies. Regions, we have 5 regions in Denmark. Just a moment. The capital region, the Sealand, the southern Denmark, the middle Denmark, and the northern Jutland. 98 municipalities in Denmark. So that's an average of around 60,000 inhabitants per municipality. This gives, but municipalities are both relatively big and relatively small. The biggest municipality is the one we are visiting today with plus 600,000 inhabitants, but we have very small municipalities of less than 10,000 inhabitants. So that's actually a challenge for hospitals who have to work with the municipalities on a number of questions. A way of meeting the challenges to future within the healthcare sector, we need to cooperate deeper and better between the participants. It's very important that we have efficient and effective hospitals, but it's equally important to have a sector with general practitioners and municipalities which actually lift the tasks that they are responsible for. By law, the regional council and the municipalities have to sign a mutually binding agreement on the collaboration between the sectors. This agreement is signed once every 4 years. That's once every election period. And that gives a kind of a stable basis to work together on. As I mentioned, the general practitioner in Denmark is often called a gatekeeper. You could have different ideas about what a gatekeeper is. A gatekeeper is not a person keeping you away, but a gatekeeper in this respect is helping the best possible way to lead you through the healthcare system. So the general practitioner, or the family doctor as we call him or her, we have a lot of female doctors in Denmark, play a key role and act as a gatekeeper to the healthcare system. The GP is my primary contact point with the healthcare system, and I contact my own GP with in principle, all questions related to my health and illnesses. Okay, so what is the future hospital program, or the super hospitals? The phrase super hospitals is not a formal phrase, but it's used often about this program. A few key figures on this slide here. We have a budget for these 16 projects which are a part of this future hospital program on 6.6 billion euros. There are 16 projects, as I mentioned. 10 of the projects are extensions of existing hospitals, and 6 projects are brand new greenfield hospitals. And the one I showed on the first slide was one of the greenfield hospitals. Of the 6.6 billion euros, which is a fixed state budget, 1 billion euro is reserved for ITC and medical technical devices. So I think this was from the politicians who decided on this plan. It was to say very clearly that ITC and technology is not a thing you should put on the hospital when you have built them. You should be integrated in the hospitals, in the planning and in the construction of the hospitals. We have a so-called efficiency, we have a number of so-called efficiency gains which have to be met when the hospitals are built. And there are efficiency gains from 4 to 8%, which shall be gained when the hospitals are built. So we are supposed to use the hospitals to be more effective and efficient. Focal points, it's much in line with some of the things mentioned from the Smart Hospital program. Focus on patients, improved efficiency, and flexible hospitals. And the need for flexibility can, well, I guess only be stressed after the current experiences with the COVID-19 pandemic. And an example of how one hospital, the North Zealand Hospital, which was the hospital mentioned and shown on the first slide, have worked with so-called 5 values. What are we actually here for? Of course, for the patient, but what does it mean? It means that we are supposed to deliver the best treatment possible. We are supposed to be a professional and efficient, effective hospital. We're supposed to be open and collaborative. We should be a welcoming hospital, and we should be a safe hospital. So that's the 5 core values defined in this project. And then there's a lot of organizing principles, which you could say is also a kind of basis for planning the new hospital. Just mentioning a few of them, maximizing the shared functions, flexibility for the future, flow optimization, maximize activities at the patient's room. All the new hospitals are built with 1-bed patient rooms, and it's a policy to maximize the activities at the patient's room. So bringing the doctor and the nurse to the patient instead of bringing the patient to the doctor and the nurse. Centralize shared functions, maximize standardization. Standardization is a very interesting concept. It's not always easy to standardize because different kinds of specialties and departments do have different tasks, different ways of operating. But if you go too far down that road, it minimizes the flexibility you need to have in your hospital. So that's quite an interesting discussion. Digitalization and automation is a key in building the new hospitals. Lots of robots, lots of focus on delivery of services, on logistics and so on. So very interesting. So what trends do we see in Denmark concerning healthcare? Just a few numbers here. Hospital discharges going up from 2000 to 2020 with 30%. That's a lot. That's a lot more than the number of Danes have increased in this period. Outpatient visits, extremely many more of outpatient visits, more than a doubling. Beds, we have been reducing beds in the Danish hospitals, and over this period with 30%. Bed days also been reduced. We have organized hospitals in different ways, in a different way, merging hospitals and so on. So today we have actually 20 hospitals in Denmark. We used to have 20 years ago 78. Average length of stay, which I mentioned before, has been decreasing rapidly during this period too. So that's some of the trends we are seeing and working with. You can't talk about new hospitals without talking digitalization. So, of course, we have in Denmark a digital health strategy. There's a lot to be said about it. I won't say it all, but coherence in treatment is a key in this digital health strategy. It's becoming more essential as multimorbidity rises and the patients are in contact with multiple parts of the healthcare system. So, as we say, there's no real alternative to increased digital cooperation. 5 focus areas, just a short overview. We are talking about the patient as an active partner, knowledge on time, prevention, trustworthy and secure data, and progress and common building blocks. I'll just mention a couple of examples here to illustrate. The patient as an active partner. The patient's ability to act proactively is a key. Patients can and should be more involved in their own treatment so that the health system interacts with the patient on the patient's terms. Better coherence in treatment is essential, giving the patient a more flexible interaction with the healthcare system that consider individual needs to a greater extent and give the patient a better overview of their own health, illnesses, and treatment plans. So we have We have some very popular apps, which we have an app called My Doctor, Min Læge, which is widely used, and a lot of other apps. Knowledge on time is the second key issue, which was also mentioned in the former presentation. So we have worked during the past decades to come from what you could call a message system to a data shared system where data should be available whenever needed. The patient wants to interact with healthcare professionals who have prior insight into the patient's pathway, and healthcare professionals want to spend less time obtaining relevant information or seeking relevant information about the patients. We have a Danish e-health and telehealth plan. We have worked on telehealth for a number of years and quite proud to be ranked as number 4 in the world on telehealth, but Korea should be even prouder because you are ranked number 1 in the world considering telehealth. So we'll try to learn from you on that field. But we have a quite well-functioning system. We have a digital health strategy, which actually also the key in this strategy is going from what you could call a web-based access to an ecosystem of apps. We have a shared medication record. I'll show you that very shortly. We have My Doctor app and My Health app also. Data and infrastructure is extremely important. Data is extremely important, and infrastructure, of course, also. We have a great number of Danish registers which have collected data from all patients in all hospitals and all medical clinics according to the same standards and definitions since the 70s and 80s. And since we have been collecting for so long time, we have the opportunity to go really far back when we want to look at the development of diseases and of treatments. We can link data from different registers because of the unique patient identifier we have, the so-called, in Danish, CPR number, which is a social security number. data sharing across the healthcare sector. We have a so-called national service platform where we share real-time, day-to-day, every minute, every second, we share data on this national service platform. It's shared between regions and hospitals, GP and dentists, pharmacies, municipalities, and citizens too. You see some of the data in the national service platform on this slide here. There are around 100 million calls to the national service platform a month, so it's a thing which is really used in the Danish healthcare sector. A brief example about the citizens' medicine. We have a so-called shared medication record, which is actually quite well functioning. You can see on the left-hand side here, the GP, the dentist, the hospital can view the patient's medication and, of course, update the patient's medication when that's needed. On the right-hand side, the citizen and the relatives, which can view and renew prescriptions. You cannot update your own prescriptions at this time yet. And in the middle, there are the pharmacy and the healthcare professionals in the municipality, which have an access to view the medication of the patient or citizen. So, try to wrap up. This was not an in-depth presentation, but it's an overview. As I mentioned, you have to come back at least in visit us in the end of 2024, when we suppose this beautiful hospital will be finished. But until then, my key messages today would be the following. We have a great future hospitals program, the super hospitals. It consists a lot of building, but there's also a lot of ICT in it. It bases on a more deep understanding and practicing on partnership with the patient. And we have to make sure that we have competent healthcare workers too. We have an ongoing discussion in Denmark how to recruit more people to healthcare. So hospitals are great, buildings are great, beautiful buildings are even greater, but without ITC, patient and healthcare personnel, they are not that great. Hospitals are essential, and from a Danish perspective, it's not only about hospitals, it's also about how we work together with the other parts of the healthcare sector. And in Denmark, it's primarily the general practitioners and the municipalities and the services coming from these two parts. Focus on continuity of care, focus on the pathway of patient, and focus on sharing data. So what's the future about? It's about these great hospitals, about digitalization, automatization, lots of things, and cooperation between the different partners too. And the second last key point, having been a hospital director for 7 years, I have a very strong focus on implementation. It's great with visions, it's great with plans, but without implementation, it's nothing. And the last issue, the so-called long haul. We have been working more than 10 years for this on this future hospital plan. We have reached a lot. We're not finished yet. We have been working continuously on healthcare IT since the 70s. We have reached a lot, but we are not finished with it. We won't probably ever be finished with that development. So the expression, the long haul, is quite proper, I think. And least, okay. then if there's nothing more here, I'll say thank you for your attention today. Thank you.
Thank you very much for this very nice overview of the Danish hospitals and what we have done and what our plans are going forward. It's always nice to hear it from someone who has been really hands-on and actually working at a hospital and who knows what's the pains and gains. So, any questions? Yes.
Thanks a lot for a nice presentation. My name is Kyung Jae-won, by the way, from Copenhagen University. And I've just learned that Denmark has reduced the number of hospitals, and now it's 20. So are you going to have those super hospitals in addition to those 20 hospitals, or are you going to replace the current hospitals into the concept of the super hospitals? And I have another question, that is, well, Denmark has reduced the number of hospitals. Don't you think that it really reduce the accessibility of the people to the hospital or not?
I have unmuted. Thank you. To the first question, no, we're not building new. We're not building more. Yes, we are building hospitals. We're building more hospitals, but we are closing down old hospitals and moving patients and staff to the new hospitals. So we are not planning to having any more than these 20 hospitals in the future. So there's a lot of hospitals who have been closed and will close some more, but then move to the new so-called super hospitals. So that's one point. Accessibility is a great question. I had the pleasure of talking to some German friends a month ago, and they told me, I talked to a Swiss friend too, and he told me in Switzerland with 8 million inhabitants, they have around 178 hospitals. That's a lot. That's a great accessibility they have to the hospitals. But are there real hospitals in the sense that we understand hospitals? Perhaps not. So accessibility is an issue. Denmark is a small country, half the size of Korea. It's quite, in Danish context, quite densely populated. So nobody has more than 50 kilometers to a hospital. So that's how it has been decided. And then in the future, there's a lot more treatments going on, not on the hospital, but in the patient's home, and with the more telehealth, a lot more will take place at the patient's home. So I think it's not a very, very big issue in Denmark today. There has been issues every time a hospital is closed down because that's how it is. The hospital has a venue for the people living around the hospital, the community around the hospital. So there's always a discussion, but I think we have found a kind of level now on the number of hospitals.
Is there another question here? Thank you so much for the presentations. My name is Jan Hillim. I'm from University of Copenhagen. And I assume that Denmark somehow resolved the issues of Gdpr when you have this sharing data, even with the relatives, that I didn't know that. And I think that might be a hurdle of Korean super hospitals or smart hospitals, because it's impossible to share data outside of the hospital or, I don't know, what's the record organizations. What is the stage of Gdpr in smart hospitals based on Peter's presentation?
Very keen on observing the GDPR, so I think we have a very strict administration of the possibilities of getting access. So in Denmark, it was mentioned we have by Camilla Foged, Professor Foged, we have quite a high degree of trust between healthcare authorities and the community. And I think that's also relevant in this respect here. We are most Danes are interested in scientists being able to use our data if it happens within the GDPR regulative and there's no personal identification and so on. So I think there's in Denmark, a relatively high acceptance of using patient data for research and so on.
Better late than never. I hope you were all able to hear what I said. So we'll give the word now to Dr. Huang from KHIDI to talk about the Korean medical device industry. Please.
Hi, ladies and gentlemen. I'm very honored to be here today to introduce Korean medical device industry. I'm Sung-eun Hwang, a director of the Department of Medical Device and Cosmetic Industry at KHIDI. Today, I'm going to share with you some facts about the medical device industry in Korea and briefly talk about what KHIDI supports the industry. Also, I'm going to suggest some agendas for cooperation between Korea and Denmark in medtech area. I will tell those things with the 4 parts, as you see. Firstly, I start talk about current status of medical device industry. Recently in the medical device industry, there are 9 macro trends following with the development of AI and robot technology. The medical device technology also advances and digital health gets a lot of attention. Besides with the person-centered healthcare, there are changes like the consumerization, the outcome-driven reimbursement, increased regulatory pressure. In the market, there are unprecedented consolidation and new entrants of global companies such as Google, Amazon, and Apple. Also, China and India emerges as a market with great prospects. In developed countries, aging population affects industry. The medical device industry has grown continuously with these trends. According to Fitch Solution, the global market size of medical device industry was $419 billion in 2020, and it will grow to $589 billion in 2025 with CAGR 6.3%, thanks to the increase of investment from government and global companies and driving towards universal health coverage. In health industry of 2020, the healthcare service industry was the largest industry and worth more than $9 trillion. The market size of medical device industry was a lot smaller than pharmaceutical industry market. However, it was the fast-growing industry from 2016 to 2020 with a CAGR 5.2%. From now on, I'm going to talk about current situation in the Korean medical device industry. The Korean medical device industry was worth about $6.7 billion in 2020. It was the 10th largest market in the world and had been growing at an average of 7.6% since 2016. The total production of medical device in 2020 was about $8.4 billion, increased 40% from previous year, and total import of medical device in 2020 was about $4.4 billion, increased 6.5% from 2019. Because of COVID-19 pandemic, amount of export increased dramatically. It was $6.6 billion, increased 78.9% from the previous year. The market size of Korean medical device is predicted to grow to $8.6 billion in 2025. In Korean health industry, the medical device industry was the smallest industry, but was the fastest growing industry for last 5 years with 7.6% increase. The Korean medical device industry was affected by the COVID pandemic, but not negatively like others. The Korean medical device industry recorded a trade surplus for the fourth time. Especially before the pandemic, the Korean industry had strengths in ultrasound devices, digital X-ray, and dental implant and devices. But after the pandemic, the Korean medical industry also has strengths in vitro diagnostics, like COVID-19 testing kits and molecular diagnostic equipment. Also, as I mentioned before, speaking of production of a South Korean medical device, we had good competitiveness in dental implant, ultrasound imaging. Due to the COVID-19 in 2020, it seems that we have done our best to produce products related to COVID-19. Likewise, we had a dramatic increase in export of medical device in 2020, so that we have two companies with sales exceeding $1 billion. Those two companies are mainly involved in IVD business, and due to COVID-19, it benefited greatly, and with this opportunity, it has grown into a global company in the molecular diagnosis industry. As you can see the graph, Korean diagnostic kits exported to more than 200 countries, and the amount of export was around $2.2 billion, increased 7 times higher than the previous year. Not only diagnostic kits, but also ventilator, patient monitor, and medicine injectors exported more. Especially amount of export of ventilator was $46 million, increased about 706% from 2019. The Korean companies that produced diagnostic kits haven't been settling for the current growth. They are also able to develop advanced molecular diagnostic equipment that previously we imported from global companies like Mantrap, Hamilton, and Abbott, etc. Back to export data, Germany was the most important country, and US, China, India, Italy was the major importing countries of Korea. The most noticeable point of this table is that almost all countries in the table imported Korean medical devices at double. Especially Holland imported about 1,200 more than last year. This was caused by the pandemic, and Denmark also imported about $15 million, more than 50 times higher than previous year. The Korean medical device industry has been invested in R&D. 1,300 companies invested to R&D with $721 million, and 4 medical devices clusters in Korea helps Korean companies to research and development. They are located in capital area as well as out of capital like Wonju, Osong, Daegu. Not only Korean companies, but also global medical device companies have invested to Korean industry. GE Healthcare built their largest R&D center and manufacturing facilities of ultrasound in Korea and produced 1/3 of their ultrasound devices. Siemens Healthineers built their manufacturing facilities in Seongnam, Gwangju, and Wonju, and produced over 60% of their ultrasound imaging devices from those manufacturing sites. Also, Korean medical devices company Mediana produced global companies' product in ODM way. Now, I'm going to explain about support project of my KHIDI briefly. The Department of Medical Device and Cosmetic Industry supports 4 parts: R&D, promoting the use of Korean medical device, global expansion, and education program. Korean government spends almost $1 billion in medical device R&D with 4 main projects. First, developing market-friendly device for global competitiveness. And second, dealing with the future medical environment and the fourth, industrial revolution. Third, realizing public healthcare service and solving social problems. Lastly, enhancing infrastructure of medical device industry. We also support 15 medical device centers of clinical trials and field evaluation based on a hospital for innovative medical device companies. For promoting the use of Korean medical device, we support to use and evaluate the new Korean devices. Through the support project, new Korean devices enhance their competitiveness of technology, safety, and efficiency. And we support 2 medical device training centers for the users' experience of Korean medical device, and one more training center will be built in 2020. For global expansion, we support 3 test centers of evaluation of sustainability. These centers help Korean companies to clinical trial for obtaining regulatory approval like FDA and CEMDR. And for dealing with enhancement of global regulations, support centers for global regulations will be built in 2021. We also exhibit Korean medical devices in international medical device exhibition through Korean medical device showrooms for global expansions. There will be no disagreement that fostering good talent is important for the industry to grow. Many universities in Korea are exploring the medical device industry in undergraduate or graduate courses. Besides, KHIDI also selected 3 specialized graduate schools, and we are striving to cultivate talent at the government level. For further details not covered in my presentation, we have an English website where you can learn more about the Korean medical device industry. Please visit the website. Next, I'm going to suggest a cooperation project between Korea and Denmark briefly, which is the most important part for this presentation, I believe. This table shows how much Korea and Denmark trade their medical devices. Because of the pandemic, Korea exported diagnostic kits, most to Denmark, ultrasound devices, and polyglycophones followed, and the amount of export was about $16 million. Denmark exported smearoscopes, most to Korea, and ostomy bag followed. The amount of export to Korea was about $45 million, and Korea has been importing more medical devices product from Denmark than Denmark has from Korea. For enhancing relationship between 2 countries, I'm going to suggest 3 agendas. Firstly, I suggest the collaborative R&D project. We are planning the project for Korean medical device companies to research and develop with a foreign company or institute, including hospital. So, I propose that the innovative Denmark companies or institutes collaborate with the Korean companies for mutually funded collaborative R&D. Actually, we've done this kind of collaborative R&D project with Singapore and UK, and we'd like to expand it with Denmark as well. Probably, we will be able to hold a seminar for a grant course to explore the opportunities between 2 countries. Second, I suggest student exchange program in graduate school. Recently, the trend of industrial education is for global, and as I told you, we support 3 graduate schools specialized in medical device industry. So, I propose that establish student exchange program for understanding and developing medical device industry of 2 countries. I also suggest to establish Korea and Denmark consortium, including companies and institutes. For supply to super hospital and smart hospital, I propose to establish the consortium combined with the strengths of the 2 countries. I'm convinced that some of the area like digital healthcare solution would be able to play an important role to run your super hospital. If it is possible, I would like to hold the Denmark-Korean MedTech Forum. focusing on certain area that we could agree with some discussion. That's all for the presentation I prepared today. Thank you for your attention.
Thank you very much, Dr. Huang, for this very nice presentation of the medical device industry and to see this really impressive growth that you are going through right now. Of course, it's partly due to COVID-19, but still. I think it's very impressive to see how KHIDI really supports all these new initiatives. That must be very comforting if you are a startup or a small medtech company in Korea. I also really appreciate your nice proposals for collaboration, which was really concrete ideas, and I hope a lot of people in Denmark will listen and capture this invitation. I at least noted myself the one about the smart hospitals, super hospitals that we are working on with Healthcare Denmark. I think I will come back to you on that one. Thank you. We will have a few questions afterwards if there is any, but first I would like to give the word to Dr. Ute Wolf Sørensen from Denmark. Dr. Sørensen is a chief physician at the Laboratory for Antibiotic Resistance at the Serum Institute in Denmark. And Dr. Sørensen will talk about the Danish effort to address antimicrobial resistance, which is an area that is very, very hot, unfortunately. Now, I know COVID-19 is something that occupies all of us right now, but this is certainly a threat that's lurking out there. So please, Dr. Sørensen, tell us more about this.
Thank you very much. Thank you to the Embassy for inviting me, Your Excellency, ladies and gentlemen. I'm from Statens Serum Institute. Statens Serum Institute would equal what you have as a public health center in Korea. And we were actually so lucky 2 years ago to have a visit from the Public Health Center of Korea regarding antibiotic resistance and antimicrobial resistance and exchanging knowledge and discussing how could we work both together but also evolve each institution for itself. So it's very interesting to be here again and meeting a different audience this time, but within the same subject. How does this work? It doesn't? Nope. Okay, so Statens Serum Institute, just a few words about it. It's the public health center in Denmark. It's been there for a bit more than 100 years. It was built and established to fight polio, which was a big issue 120 years ago, and other infectious diseases that spread rapidly, not only in Denmark, but in the whole world. And at this time, there were a lot of public health institutes built in Europe. So when you go and visit all the main cities in Europe, you will find institutions there that equal Statens Serum Institute, like the Robert Koch Institute in Berlin, or some of the very, very nice institutions in Paris also. They are all built at the same time, and when you look at the architecture, they're all very similar. So I'm a medical doctor by training. I will not talk very much to you about medical devices, although that's a very interesting topic, but I will try and discuss with you what could be interesting for you to develop, and maybe also what have we used in Denmark that can be fruitful for you to use. But I will be talking about antimicrobial resistance, and as you probably know, this has been deemed by WHO to be one of the main health threats for the human population in the world. It's particularly a problem for low and middle income countries, but it is also increasingly a problem for high income countries, so it should not be forgotten there either. And WHO developed in 2015 a global action plan where they came up with 5 different ways of trying to solve the problem and trying to counteract it. And both Korea and Denmark did follow that recommendation, and in 2017 developed their action plans to counteract antimicrobial resistance. But we know that time is running out. It's just like the climate crisis. You need to do something if you want to control and contain it. So why is antimicrobial resistance a problem, and how should we consider this? And it's quite interesting for you to know that what makes sense from the very beginning is that if you use antibiotics, you will create resistance. That makes sense. It sounds logic, right? You have a microorganism that can be a bacteria, but it can also be a fungus or something else. You try to treat the patient being infected with this microorganism with an antibiotic or an antimicrobial, and then either during the treatment or following the treatment, the patient might be carrying a resistant bug as an outcome of this. The patient itself might actually be cured, but the microorganisms in the body of the patient might have become resistant, and that is really the problem that we are trying to fight. So there's a direct relation between use and resistance, but then all these factors come into play, and that is why it becomes very complex and very complicated. So the first thing that we need to know is not only humans use antibiotics, you also use it for the animal side in the livestock production, but also for pets. And they also carry bacteria that then can become resistant, and they can be sharing bacteria between humans and people and animals. We know that when you live together with a pet, in Denmark, I think 40% of all have a dog and many others have cats, then you know that you will share some of the bacteria because you're living close with the animal. So if the animal is treated with a lot of antibiotics, the animal might carry resistant bacteria, and then that might end up in the human person causing an infection. We also know that at places where antibiotics are produced, and that is primarily in India and China, there's not a lot of control with the wastewater systems, and we know that many of the factories that produce antibiotics, they release antibiotics into their wastewater, and that causes resistance development down the stream. So if you go to the production sites in, let's say, India, you will be able to take samples from downstream of a factory, and you will find that the rates of resistance are terribly high, like frighteningly high. But we know on the human side, so north of the arrow, you see all the human factors that affect antibiotic use. That is also the socioeconomic factors. It's the travel of people and foodstuff. It's how much are patients moved around, because patients are the ones that are fragile, so they are the ones that need to be protected. How appropriate is the use of it, and what kind of control measures do we use? And on the downside, you can see, are there antibiotic residues? As I just talked about, that can be in wastewater, but it can also be, let's say, in food. Is there cross-selection? Maybe you are treating with one antibiotic, but then the resistance develops towards a different antibiotic. That can happen. There's gene transfer, there's non-antibiotic selection, and then there's a question of how long do I treat and how much do I use. And that is a very huge problem in many of the Asian countries, that is that the usage is out of control. A lot of patients take antibiotics not the way they were prescribed, but they take too much, or they take it for too long, or maybe even, which can be worse, they take a little, then they take a pause because they're feeling better, then they start again, then they take a pause, then they start again, and that will certainly create resistance. So antibiotic resistance is really just the ability of the bacterium to protect itself from its surroundings, and if there's antibiotics in the surroundings, then it will protect itself from there. If there's something else in the surroundings, that will be the protection mechanism caused. The bacterium is just one cell, so all that it meets, it has to be able to counter in that cell. It needs to have all the competences just in one cell, and that's the big difference between us as humans and the bacteria, is that we have very different and many different types of cells, and we work together as an organism. So bacteria become resistant to antibiotics as soon as they meet them. Not most of them die, of course, but some will have the time to react. You can measure this by examining it in a petri dish, looking at, is the antibiotic killing the bacteria? You can see that here the background is actually the bacteria. These are the pills with antibiotics. And then when there is a big zone around, the antibiotics worked. It killed the bacteria around the antibiotic. When there is no zone around, the bacterium has become resistant. AMR is also a huge burden related to cost of health expenditures. There have been quite some nice calculations done by the World Bank, and we know that if we don't react to antibiotic resistance, then the cost of health treatments, the cost of hospital systems will explode and become really expensive. So in Denmark, we've been working with surveillance, and that is what I will spend some of my time talking about. And we have done that using what we call a One Health approach. So we look at not only the human side, but we look at the veterinary side, we look at the livestock production, and we measure both the bacteria that cause infections, but we also look for the bacteria that might be indicator bacteria for resistance mechanisms. And we do that from 4 different sectors coming together. So you can see here we have food, animals, and food. We have the zoonosis being measured. We have on the human side the clinical isolates, and we have antibiotic consumption. And the system was established 25 years ago, so it's quite old. It has a long tradition, and it has a certain flexibility. So all the small bubbles you can see, those are the new things that have been introduced into the system over time. And Korea has a wonderful surveillance system that was developed just recently, or the old system is back from 2008, but the new system is from 2017, I believe, and it's very, very impressive. It does the same thing, and it already calculated with all these extra bubbles because they were able to draw on the experience from countries. So also here, Denmark and Korea have been able to exchange. So why did we choose to have it as a One Health activity? Maybe I should change this a bit. We have a very old tradition for monitoring salmonella, and salmonella was watched then from the veterinary side and from the food sector side and from the human side, how many people suffer from salmonella infections. And you can see that the Danish Salmonella Center was founded in 1938. And so from there, we have an existing collaboration, and we have been able to use that and broaden it into antibiotic resistance. So then comes Denmark, the system I will tell you about, which was established in 1995. We have One Health research groups working with AMR monitoring systems, and you can see there's a short abbreviation here called WGS, that means whole genome sequencing, so that's the more modern way of looking at bacteria since 2008. And we have a One Health Research Center that is related to veterinary preparedness. Everything that causes infections on the veterinary side also is at the Public Health Center, and so we can have collaboration on that. And finally, we participate in a lot of EU projects on resistance. So taking you back, I will now talk a bit about what do we then survey. So here we are back watching the resistance part only. You can see on the top comes the resistance that is examined and monitored on the food side. Then comes the resistance that is monitored on the animal side, like the livestock production, and on the bottom you see what happens for humans. And we're really happy that we are having a system that covers 100% of what is happening. We receive results from slaughterhouses, from veterinarians on the food side, and on the human side we receive all results from all samples that are ever taken. And on the antibiotic usage side, we receive it from Sundhedsdatastyrelsen, which is our health data authority, and from Denmark Statistic on patient treatment. I remember that Peter talked about length of stay in hospitals. We know for our calculations, we use a length of stay that is only 2.4 days. So a patient is very quickly in and out again, which has an impact on then how do we react to that. This is the total antibiotic use in Denmark. You can see here the antibiotics used both in the veterinary sector and in the human sector. The purple bars are the growth promoters, which were used back in the 90s. Then they were voluntarily stopped, and later on there was an EU decision to stop them also on a legislation area. The blue bars are the antibiotics used for treatment of animals, and the green bars are the antibiotics used for humans. And you can see that they have decreased, the human part has decreased quite a lot during the last years, 5-6 years, and from 19 to 20 it fell by 23%, and that is due to COVID-19. Now we're back with the resistance. You can see how we over the time built the surveillance system. So we started out covering only 15% of the population in a pilot study, and then over the years it was built as a national surveillance study, so now it covers 100% of the population. So when you build a surveillance system, when to watch and when to react, and that is quite interesting because you probably see here that there is a bar that kind of tops up a peak in the capital region of Denmark in 2018, I think it was, and simultaneously you can see that in the neighboring region, the Zealand region, it seemed to decrease quite significant in 2018, and that was why at that time there was a shift between how patients were moved around and how they were treated. So some of the patients that earlier used to be measured and watched in the Zealand region, they were then watched in the capital region. So sometimes it's just an artifact in the way you measure things. We don't know that for some antibiotics and bacteria, it's really easy to see how they connect. So if you watch fluoroquinolones, which are some of the most used antibiotics in the world, not in Denmark, but in the world, and in Korea it's used quite a bit, you will immediately see development of resistance. For other antibiotics, not the same happens. It becomes more complicated and more complex. Then what you don't see if you watch, you just follow a strict standard surveillance program is what happens at the very bottom of your curves. If you look at the left side, the y-axis, you can see here that although these figures show a dramatic increase in some of these bacteria, I will be telling you more about them, it's not like it's a lot of high numbers. So when you look at the number of bloodstream infections in Denmark, there are around 3,500 patients a year that have a bloodstream infection with E. coli, which is the most common bacterium causing bloodstream infection. But when you look at how many are then highly resistant, it's about 200 last year. So here we don't necessarily cover things when we do a broad surveillance system, and so we need to look at each individual sample, what exactly happens, what kind of resistance mechanism does it carry, and how is it spread within Denmark. I will show you for VRE, that's the one at the bottom left. VRE stands for vancomycin-resistant enterococci. Enterococci are a very common bacterium that exists in the intestine of all humans. And when they become vancomycin resistant, they're very, very difficult to treat. And you can see that here we have orange bars which show a certain subtype of the bacterium, and you have dark blue and lighter blue bars. So here we use very modern ways of analyzing things, so we can see not only how many VRE are there, but what types of VRE are they, and are they related to hospital outbreaks. So here's a certain clone that we found in 2015. You can see the tiny map of Denmark showing that all the isolates that we received, they were sent from the capital region and the region of Zealand. And so that was an outbreak going on in the hospitals and being shared between the hospitals of the region. It was of great concern. We know that it's associated with very sick patients, but also with a very high rate of mortality. So patients die quite often either with or because of VRE. And this particular strain was almost exploding at these hospitals. And in 2015, we figured out that it not only was in the capital region, but it also had moved to the small island that is called the Ferry Island in their hospital system. So it was our strain that was passed on to a neighboring island and a neighboring country. And 2 years later, we found it in Greenland. Greenland, as you might know, belongs to the Kingdom of Denmark, but is independent, but we still have a common health system. and patients are sometimes referred to the capital region in Denmark when they are very difficult to treat. And here patients had been in Copenhagen and then they went back to Greenland carrying these highly, highly resistant bacteria. So then we watched this cluster type, which we were really worried about, and you can see with the red circle I highlighted the one that we were watching and that we were really concerned about, and we were concerned about that it was related to not proper cleaning of the hospitals, but also to patient movements. And then you can see how it constituted 51% in 15, 64% in 16, 63% in 17, and then it has been diminishing. And now in 2020, it's only 2%. So a clone comes and goes. Sometimes that's related to the way we react. We did change our cleaning systems. We did use different ways of cleaning. We did buy a lot of modern machinery to do better cleaning at the hospitals. And then it disappeared. But instead, you can see that there are others that are now emerging. So the way that we are watching this is it needs to be very, very detailed and very, very down to the different individual clone to see what happens. Then we're going to MRSA, a problem which has been known and acknowledged since the 60s, actually. And MRSA is one of the good stories in Europe, at least, because many of the European countries had lots of outbreaks in the 70s and 80s. And then within the last 20 years, most countries developed different actions to counteract it and to fight it. We are monitoring it quite closely in Denmark, and you can see that is not going too well because the number of cases keeps increasing. But what you can see here is that all these cases happen primarily in the community and not at hospitals. So it's not a hospital problem in Denmark. But it's a livestock problem. In Denmark, we produce 36 million pigs a year. That's 6 pigs per inhabitant. And these pigs are, of course, treated with antibiotics if they need it. And the use of antibiotics in the Danish livestock industry combined with giving them zinc, giving them copper. You do that when the piglet is taken from the mother to make sure that the intestine does not suffer from taking it away from the mother. So antibiotics plus zinc plus copper cause the development of resistant in a bacterium that is shared between humans and pigs. And then the resistant clone went back to the human population, and now we have what we call livestock-associated MRSA. We've been worried that that might be introduced into our hospitals because they are very resistant. Luckily, they are not very pathogenic, so you don't necessarily become very sick. You have to be already very vulnerable as a patient to have an infection with livestock-associated MRSA, but if you do that, it is quite risky for you and causes high mortality. And then the very last one we call CPE, which stands for carbapenemous producing enterobacteria. We are back in the intestine of the human. These are the common bacteria in the human intestine, and you can see how they also have been increasing over years. And there are 4 different types that dominate the picture in Denmark. And the one that is called NDM, this is the blue one. That is one that is called New Delhi mechanism. It was first discovered in India, and then it went by traveling people and food from India to the rest of the world. Here we participate in a European study where we look at how much of these CPE exist in the European hospital systems. You can see Denmark as this tiny little attachment here, appendix, that's Denmark. You can see how it in 2050 already had interregional spread. That's because we have the hospitals working very close together within one region. You also can see that there are some countries in Europe that are still not affected. And then in 2018, this is what it looks. You can see there's much more red color, which means much more interregional spread. And there are, in Southern Europe, very, very big problems with endemic clones. That means they are the same clones circulating in the hospitals. And in both Greece and Turkey, they have by now developed systems where people coming in who are not carrying highly resistant bacteria are isolated to make sure that they are not being infected with highly resistant bacteria just from being at the hospital. I believe the rate in Korea also is quite high. I can't go back. Well, yes. So in Korea, the number of these cases is very, very high in your healthcare system, and that is probably related to antibiotics being used too much in your community. So AMR is a global issue. AMR travels with food, it travels with patients, it travels with travelers, tourists, whoever goes across the world. We know that the more people travel, the more we have spreading of resistant bugs. Here we're back looking at Klebsiella pneumonia, which is one of the most frightening, highly resistant bacteria. And you can see how it over time emerged first in one country and then it was moved around and discovered in other countries of the world. And you can see how the resistance rates are highly associated with the use of antibiotics in the Asian countries because this one came from the Asian countries. Down here you have the antibiotic use in India, you have the antibiotic use in Pakistan, and you have the antibiotic use in, I think it is Thailand. So in countries where you have a very high rate of antibiotic use, resistant bacteria develop, and then they travel with food, with people, maybe with animals to other parts of the world, and they become a problem at the second where they are introduced in a hospital. This is also, as I started saying, a problem for the high-income and the low-income countries, but it becomes much bigger for the low-income countries. They are the ones on the right. Here you see different bacteria that are monitored all over the world, and the ones I was showing you before would be the ones that are red here. And you can see in high-income countries it is a problem, but it's not a huge problem. In low-income countries, it's a very, very big problem. And since we have a global world, it becomes a problem for us. And then spread happens faster these days due to air traffic and moving around. And it's quite interesting to do this study again now that air traffic has been so much reduced due to COVID-19. So it would be very nice to say how that then maybe has stalled some of the movement, not counteracted it, but maybe stalled. So we have 25 years of doing surveillance. We know that the detail of the data means something. We know that the quality of the data means something. We have a very high coverage. We have a very well-functioning feedback. So every sample we take, every result we get is fed back to the clinicians, which is really important for them to be able to choose the right treatment. We have annual deliveries to all our interest groups and policymakers, and we do reports to our politicians so they can support us, which is really important. And then we have deliveries that go throughout all systems and become a One Health work. And why does it work? It does work because it is financed by the Ministry of Health, so it becomes a fast and continuous work that is going on. It has a fundament of standard deliverables, and then we have these results that are fed back and used. And then finally, I think one of the advantages is that Denmark is such a tiny country, so I know all my collaborators in the rest of Denmark, and I think that definitely makes things easier. So I can call them if I see something happening. And then on the positive side, we know that what has been driving, what's happening? Here it is. On the positive side, we know also what has been driving a lot of this is that the food safety increased a lot when we started building these surveillance systems. And together with the food safety, we had better welfare, and our export of food and goods was stabilized and increased and is today one of the most important parts of the Danish economy. So our challenges. I think Peter already touched upon that. We have much more chronically diseased. We have very highly specialized departments, very few hospitals, and we have a very, very high flow of patients. We have much more equipment. Bacteria, they love equipment, plastic, tubes, catheters. So a lot of foreign bodies. We have much more patient movements. I told you about the VRE. That was the first bacterium I showed you being highly resistant. And we know that from watching patients that some of these patients, they might have been admitted for or at hospital for a long time. They often stay up to 60 days, which is unusual in Denmark. They are very, very sick patients. But we also know that within these first 10 days that a patient comes in, they can be moved to up to 200 times. So if you move patients around like that, you really increase the risk of infecting them with bacteria. Then something I haven't been speaking about is that antibiotic production is monopolized. There are very few companies today in industry that produce antibiotics, which risks that some of them simply will not be produced anymore because it's not attractive anymore. And finally, we know that development of new antibiotics is slow and not attractive for the industry. And then came COVID-19. And actually in Denmark, it was in many ways quite positive, not solely positive, but we had fewer outbreaks with travel-associated infections. We had much less antibiotics used, both in Denmark and in the European or EEA countries. And we gained a lot of knowledge into the use of antibiotics. Why are people using antibiotics? Are they thinking, are they believing in that antibiotics will help them prevent COVID-19? Do they believe that they can treat COVID-19? In some of the countries they do. We have much better infection prevention and control at hospitals. It is very important that the super hospitals include infection prevention and control, and they don't do that enough. It hasn't been in the focus. There's going to be an authority, an agency developed by or established by the European Commission, which is called the HERA, and which will be an agency for infection prevention and preparedness. And then finally, in Europe, this drove the treaty, the WHO, the FAO, and the ORE, which are the animal health organizations, and the UNEP, which is the environmental organization, going together, and hopefully that will work as well. And when you look at the right side, you can see how antibiotic usage dropped due to lockdown. This is the first lockdown in Denmark. This is the second lockdown in Denmark. And here, simply patient didn't go to their GP anymore, but probably also they didn't suffer from infectious diseases because they stayed at home, and that decreased the antibiotic usage. And in parallel, you can see how the infections with pneumococci, as you might know, cause pneumonia. They have a very high mortality, and you can see how it decreased during 2020 because kids were not at school, and kids are quite often the ones that carry it and spread it in the community. So what else do we do? We have detailed analysis on antibiotic use. We have a national surveillance on healthcare-associated infections in Korea that is combined with the AMR monitoring. We have modeling systems for the spread of AMR. We have what we call a microbiome that will take a lot of lectures explaining about, but it really is about finding resistant genes in, let's say, wastewater or feces. And we have participation in international research. We do clinical research also. We are really good at doing antibiotic studies, so that could also be a very interesting place to start to have collaboration. We have public-private partnerships related to development of new antibiotics, and we do partner with international institutions. And then 2 years ago, the Danish government established ICARS, which is the International Center for Antimicrobial Resistance Solution, which is a center that works on improving and supporting low and middle income countries in their work against antimicrobial resistance. And I think that's it. Yes, thank you.
Thank you so much, Dr. Jensen, for this interesting, although a bit frightening presentation. But I'm very happy to see that you are monitoring the numbers so closely, so we should have a chance to spot if there's anything coming up. So time is running out, but if there is a question for Dr. Jensen and also for Dr. Huang, it's very welcome now. No? We're getting close to lunch and evening, I guess, in Korea. Yes, okay. Thank you very much.
Thank you.
So Thank you so much to all the speakers for your great contributions today. And thank you to the participants here in Copenhagen being here with us today, and also for all the people listening from both Korea and Denmark online. I have the honor of giving a few closing remarks now, and I would like to start by saying that I have been working with Korea for the last 2.5 years as a focus country in Healthcare Denmark. And I'm so impressed with the pace that you are moving things with, the outreach you have to the world, and also your very high level of medical and technological solutions. And furthermore, I think your curiosity of what is going on in other countries is very valuable, and something that we are also trying to do in Denmark to learn from other countries. Because the more we can share our experiences and knowledge and learn from each other, the faster we can move towards a more sustainable healthcare system. So for those of you who do not know Healthcare Denmark, we are a public-private collaboration, non-profit. We have partnerships with the 3 ministries: Ministry of Health, Ministry of Business, and Ministry of Foreign Affairs. We also partners with the Danish regions, some of the municipalities, the universities across Denmark, and of course with a lot of private partners, ranging from both the big pharma companies to smaller medtech companies. And our most important role is to communicate the Danish strongholds within life science and healthcare to the outside world, and to establish this contact with important stakeholders in other countries. We receive a lot of high-level delegations to Denmark, typically stakeholders that are interested in learning more about the Danish healthcare system. And actually, we are very fortunate that the president of KHIDI will join us here in Denmark later this month with a delegation. And the week after the president's visit, we will have a visit by the president of HIRA, the Korea Health Insurance Review and Assessment Service, which we look very much forward to. So when we receive all these delegations, we learn what is top of mind for the countries visiting. At the same time, we get a very good insight in both the strongholds and the pain points that other countries experience. And I think there's a lot of overlap between Korea and Denmark in that respect. Definitely, the Smart Hospitals project in Korea is very much aligned what we are doing with the super hospitals in Denmark. We still have a lot to learn in Denmark, but we also have a lot of experiences already. So there's a huge potential in collaborating around the smart hospitals or the super hospitals. Or as the president of KHIDI said, maybe in our collaboration, it will become super smart hospitals. Elderly care is a very important area in both countries, with aging populations and lack of hands and resources. And likewise, the handling of chronic diseases is something we will need to handle in new and innovative ways to overcome the rise in number of patients and comorbidities. Another area of great concern in both countries is the mental health of our populations, which has definitely been challenged during COVID-19. And Healthcare Denmark has recently made a publication about the Danish approach to mental health, which has created quite some interest in Denmark. And I've brought some copies here today. You're welcome to take, and it's always also available online and actually also in Korean on our homepage. Finally, COVID-19 is of course top of mind for all countries. And some of the solutions, like the development of vaccines, require huge efforts and has long-term perspectives. But there may be other low-hanging fruits, easily implemented solutions or technologies where we can also share best practices. As we heard earlier today, the Minister of Health and Welfare in Korea and the Ministry of Health in Denmark has signed a collaboration agreement to further strengthen the collaboration. And now I think that the Danish Minister of Health is planning a visit to Seoul in December, which we look very much forward to. So I think there's a great willingness and interest in collaboration from both Korea and Denmark. And with the great work of the embassies in both countries, the work of KOTRA and activities like this one today, I think that we will definitely come a long way. So with that, I would like to thank you all and wish you a nice afternoon in Denmark and a nice evening in Korea. And I hope that all the people that are here present today will join us for lunch and more discussions. Thank you very much.